Hello, everyone. My name is Steve Dennell, and I'm the National Lead for Post-Acute Certification with the American Heart Association. And welcome to the American Heart Association's Heart Failure Expo. Today's session, Post-Acute Care Certification Process, will be presented by Dr. Carlos Telechia, Medical Director of Beth Abraham Center for Nursing and Rehabilitation in New York City. Before we begin, I'd like to walk through a few items regarding the structure of this virtual session. First, this session will be recorded for the audience to view after the event. Please allow for 24 to 48 hours after the event to see the recordings on demand. Recordings will remain available for viewing for 30 days following the expo. Second, after the main presentation, we will open the conversation for questions. I encourage you to type in your questions as you think of them throughout the presentation. To enter a question, locate the live chat at the bottom of your screen and type your question in the dialog box. We will field as many of the submitted questions as possible during the last 10 to 15 minutes of the session. Finally, if you have any issues with sound or visuals, please use the chat box and a person will help troubleshoot your issue. With that, I would like to pass the program along to our speaker. Welcome to HFX.
Hello, my name is Telechia. I am the Medical Director at Beth Abraham Center for Nursing and Rehabilitation. I've been the Medical Director here for a little over a year, somewhat of a new position, new building for me. But luckily I've been a part of this process with the American Heart Association to create our post-acute care heart failure program here at Beth Abe. So I'd like to share some information for you all to help you with the process if ever you guys are going to jump into it. So to begin, of course, for disclosures, I have no financial ties or relationships that exist in regards to this presentation. Before I jump completely into the heart failure program and what it takes to be certified, I want to give you a little bit more about the background of why we did this, what we were looking to accomplish. So this has taken a little bit over a year since I started at Beth Abraham. We wanted to improve the level of care that we're providing to our patients. We are a 448-bed facility, so quite a large facility in the Bronx. Expanded our subacute rehab to 112 beds. So we have about 331 long-term care beds and 117 or so subacute rehab beds. But in doing so, with the subacute rehab world going the way it is, we seem to be taking care of more acute and ill patients in this setting. So with that, we came up with the idea to ramp up the type of care that we are providing. One of the main diagnoses that we get is congestive heart failure. It's also one of the leading causes of readmission to the hospital. So we went down this path to start what started off to be just a telemetry program where we can help the hospitals complete their acute care for congestive heart failure. But act a little bit of guidance, and that's where the American Heart Association came in. So through this presentation, you'll see me talking about things that we're doing, but also that are required from the American Heart Association to be certified as a heart failure program in the post-acute care setting. There's a couple caveats with that as well, like I said, because we started a telemetry program. So we have one unit, which is our quote-unquote cardiac unit, where we have telemetry beds and remote monitoring, sort of like a Holter monitor but extended. But that's not necessarily a requirement from the American Heart Association. Association to become certified. So through this presentation, I will describe the steps that are needed to implement a multidisciplinary program at your facility, or what it took to be certified at ours. You have to understand the role that each team member plays in the heart failure program. There has to be ways to improve it, so you identify clinical modalities and improve the success of the heart failure program. And then finally, describing the care coordination in the pre-admission, admission, discharge, and post-discharge process. All those have their own roadblocks and difficulties and challenges, but with a little bit of organization, it becomes actually quite simple. So the first step that you're going to want to do when you get this program, what we did is, of course, designate a captain and a team. Mind you, we've been working on this for over a year, and the American Heart Association is going to require you to have at least 6 months of data. So we started this program about October of last year, and we were just certified about 2 weeks ago. So there is a lot of work and nuances that go into this to be successful, but it's a steep learning curve, and so you just want to get through the kinks once you start getting this program rolling. So I was designated as a champion. I would have to also say my administrator was very involved in organizing the team, putting the protocols together, but we worked in tandem amongst us two to organize the program. You have to then designate team leaders from the medical department, the nursing department, therapy, dietary, social work or case management, and the pharmacy as well. What helped us with getting this organized was really to get with the guidelines, which was provided by the American Heart Association. Really, it's clear and concise what is expected from the acute care setting and the post-acute care setting, with evidence-based practice on what we should be doing with our heart failure patients. Then you're going to want to decide to oversee the adherence to the guidelines and how you're going to improve the quality of the care that you are providing that is congruent with those guidelines. And so to put it to something that able to be monitored over time, you're going to want to put these into progress notes, order sets, algorithms, because you're going to want to gather that data collection, because the American Heart Association is also going to want to see you improve your quality and submit your data to them to show that you're improving the quality of care that you are providing. One other piece is the education of your staff. So we are still growing. Our telemetry unit is still growing and evolving, but we have to continue to educate our staff members so that they can educate and treat the patients accordingly. One of the big questions I had with the American Heart Association is, do I have to have a certified heart failure educator to come in and educate my staff? But that's not necessarily the case. As long as you are with the guidelines, know the evidence-based practice, and you have your team leaders educate your staff members and team members on it, that is documented and submitted, that is good enough to move forward. So like I said, the four modalities and the different settings that you're going to want to organize to make sure there's a good flow of care for your patient, good continuity of care so that they adhere to the recommendations, is the pre-admission process, admission process, discharge, and post-discharge process. So there's a lot of team members or members of your facility outside of the direct team that are going to be involved with this. Like I said earlier, you're going to have your nursing staff, your medical team, social workers involved. But you have to gather information before the patient comes. And I know in my experiences, you don't always get the proper paperwork for your patients coming from the hospital. So to get your liaisons that are in the hospitals to gather this information for you before they come in, you have to delineate that to them, and that helps tremendously. That's making sure that you have an adequate and accurate medication list, a discharge summary, follow-ups do they need, their vaccination history. And many of these things are talked about on the admission process, but you can save yourself a lot of trouble by getting these things in the forefront. Same thing with important studies that were done. Did this patient have an echocardiogram before they came to you? That's one of the GET guidelines, that their left ventricular function was assessed or plans to be assessed. So was that done, or is that planned to be done? Because if not, you need to be able to have a plan of how you're going to adhere to that guideline. How are we going to make sure that we've assessed this correctly for our patient? So like I said, that goes along even outside your facility with the hospital liaisons talking with the case management and hospital team before the patient comes to your facility. Once they're admitted, now the transitions of care from the hospital to your facility is quite important to make sure no medications have fallen off. The follow-ups are set in place. But what we've done to help ensure that none of these things are missed is an order for heart failure patients. Once our liaisons have identified a heart failure patient who's coming for our heart failure program, that then triggers certain parameters on admission documentation, which then reaches the floor once we get the PRI to put in the order sets for cardiac telemetry. And once that goes in, a heart healthy diet pops up, cardiology follow-up pops up, and they need to be within 7 days. We have cardiology here now on call 24 hours a day, but he's here at least 1 to 2 times physically during the week. And there's a lot, like I said, we have 448 beds. So how do we ensure that this patient is seen within 7 days of admission? That goes in order set, that it signify that this is a heart failure patient, this is a telemetry patient, new admission, so that patient is going to be seen the next time the cardiologist is in-house. So of course on admission, you'll go through advanced directives, previous past medical history, surgical history, their vaccinations. That goes along with the discharge paperwork and the patient. And we also have, I have a nurse practitioner now who works in the evening times from 5 p.m. to 11 p.m. Her sole job is to take care of emergencies in-house, but to also do the intake admissions for all, or complete the intake admissions for all patients. And there is also an order set, a template for her to complete to make sure that for heart failure patients, we are getting with the guidelines, and if not, what are we going to do to get them back on? Was this patient discharged on an appropriate beta blocker? And if they weren't, how are we going to address it? And this is part of the template that we've created in order to address that. So once they come through, we have developed a cardiopulmonary rehabilitation gym, a heart healthy diet, evidence-based practices. Like I said, we have the telemetry unit. Cardiology is here 1 to 2 times a week, and I'll call 24/7. We have admission labs. Like I said, if the echo on file, we get an echo, EKG, chest x-ray. We sort of do our own care here if we don't see that done from the inpatient setting. Once they have completed their cardiopulmonary rehab and they're ready to get back to the community, we have to make sure that there's a good transition there as well. One important caveat that I have to put here through their stay is education. You have to document that the patient is properly educated the process of their stay in subacute rehab for heart failure. Their dietary habits, their lifestyle habits. If they're tobacco users, are you doing tobacco cessation? Have you educated them on proper exercise and medication compliance? What I do with my patients is I go through the medications one by one and let them educate them on what each medication does to help show them the importance of taking the medication. But I also go through what are quote unquote red flag signs. So the red flags in heart failure, shortness of breath, leg swelling. When you're going to sleep, are you able to lie down flat? Are you getting more short of breath from one day to another? Do you have to change the amount of pillows that you're using? These sort of things. Are you weighing yourself every day? And when you see these changes, you need to be talking to your primary care provider or cardiologist immediately so that you can then do some management as an outpatient or at home without having to go back to the hospital. So that discharge planning with education is quite important. Of course, we always get DM durable medical equipment if they need it. Make sure that their home environment is appropriate for them. Do they have social support? Do they have somebody at home? Or do we need to set them up with a home health attendant or skilled nursing at home? What are their follow-ups? And so one of the get with the guidelines protocols is to make sure that there's cardiology follow-up within 7 days of discharge. Now, like I told you earlier, we make sure that there's cardiology follow-up within 7 days of the discharge from the hospital to us, but we also want that when they get to the community, right? Because that's really the danger point. There's still oversight at our rehab facility, but once they get out to the community, where's the oversight? Now the onus is on the patient to get back to their physicians, care of themselves. Hopefully they learn something from the hospital and from us. So we make sure that we have scheduled a cardiology appointment and a primary care appointment for the patient before they go home. Once they do get discharged, the biggest hurdle that we had to overcome is the post-discharge follow-up. Right? We have now followed up with patients within 48 hours of their discharge, within 7 days of their discharge, and then 30 days of their discharge. We've sort of gone above and beyond in that we don't only call them within 48 and then 7 days, but we also call them until the 30 days. So we call them before 48, we call them before 7 days, 14 days, 21 days, and then 28 days to make sure that there's congruency and there's not this 3-week gap before our last phone call to make sure they followed up with their doctor. Did they get their medication? Do they need help getting their medication? And there's a large algorithm that we've created in that if it's just a medication issue, that they can talk to social to somehow get their medication delivered to their house. If they are unable to get transportation to their cardiologist appointment and they miss their appointment, can we get them transportation to their cardiology appointment and try to make a stat appointment so they don't get lost to follow up? But what if they have some of these red flag signs 3 days after or 2 days after they get discharged from our facility? At that point, since they haven't followed up with their PCP or cardiology, that most of the time is routed to either me or our cardiologist to have a discussion on what to do next to avoid hospitalization. So like I said a little bit earlier, the heart failure program will need to implement care based on relevant accepted practice guidelines. You don't just put a patient on atenolol. You need to be putting the patients on the appropriate beta blockers like metoprolol succinate or a carvedilol. So like I said before, we also develop these templates and order sets so we can help track and adhere to the guidelines, collect the data on what we are doing, what the hospital may be doing, what we can do differently, how to improve. I'll show you guys some examples of this in a second. And that goes along with the quality improvement. So this is an example of one of the templates that we have. This is the template for the nurse practitioner on admission. Full note template. This is an add-on to her admission note, her intake note. And this goes with really the basic guidelines from the guidelines from the AHA. Does this patient have heart failure? What's their ejection fraction? Is it reduced or is it preserved? because that's also going to delineate what sort of medical management you have. And it's as simple as her putting an X on these quotations on the side of parameter. And that's something that I review then when I'm doing the history and physical. It's something that the cardiologist reviews, but the cardiologist also has something similar to this on his template to help address everything that gets missed in the medical record or missed for the patient's care. Then when it comes to quality improvement, which I've been talking about, we are doing quality improvement every 3 to 6 months. Now, I have a monthly meeting at the very least with the heart failure program team to talk about any pitfalls that we are experiencing or any road bumps or any improvements that we can make. For example, one of them was heart failure diet, was a healthy heart diet, which we were now giving to some of our heart failure patients who are rooming with patients who may have not had heart failure. And so they're eating a salad while their roommate is eating, some roast beef or something. And so they start complaining that why are they getting this food? So what we've done actually is now our whole floor that we have the cardiac unit on is now getting the heart healthy diet. So there is no question that everybody's getting the healthy foods. And if they want something different on the side, then we can discuss it, but it's a blank slate process. But as far as the actual quality improvement, I go through the charts, and that's why the templates help so much, going through what is X'd out, and I compare it to what medications the patient actually had compared to what was happening in the hospital before they came here. So this is an example of assessment of the left ventricular dysfunction. Was an echocardiogram done in the hospital? Did they have any sort of modality of assessing the left ventricular function? And if not, did we do anything about it here? So as you can see here, these were the number of charts that I reviewed per month. I did it at random. And I saw which ones actually had an ejection fraction on file, which didn't. And I allowed for about a 14-day grace period, being that the cardiologist would come in within 7 days of the patient's admission. If the patient was admitted on Wednesday, cardiology came the next Wednesday to assess the patient, and then order an echocardiogram because there's nothing on file. Then I would allow another couple days to go by to make sure. If it wasn't, then that's when it was missed here. So we weren't terrible, but obviously room for improvement. In a 6-month period, about 73% of our patients had an echocardiogram and an ejection fraction on file. So I about 2 to 3 of these every 3 to 6 months. The AHA is going to require at least 2, but it helps with the modality to want to continue to improve. The benefit of all this, why you want to go through all of this rigmarole to become certified with the AHA, is not only because it helps with the guidance of how to care for these patients. There's a lot of tools that they provide you for quality improvement, for post-acute or post-discharge follow-up, but it helps your relationship. I believe there are only about, if I may be wrong, but not by much, I think there's only 8 or 10 subacute rehab facilities in the nation which are actually certified by the American Heart Association. I believe our facility is the first in New York to be certified by the AHA. And my MO is not necessarily to improve the marketing. My MO is to improve the overall care, which get with the guidelines and the guidance by the AHA helps me with. But beyond that, the hospitals understand now that we are a certified heart failure program. We don't just talk, we walk it. We want to improve the care of our patients, being that heart failure is one of the leading causes of readmissions to the hospital. So that garners a trust with the hospital system when they know that the AHA is behind you and that you are doing continual quality improvement and getting with the guidelines to provide good care. And that's helped our relationship with the hospital tremendously. So this is a little bit more like I told you. At the end of your quality improvement, you always want to find ways to improve the metrics for your care. This is an example of our Heart Healthy diet. It's much prettier than this in person. So I just grabbed the actual font and pasted it onto here. But essentially, you want to limit sugars you're eating, low fat, low sodium diet, but you want it to be appealing to your patients. And that concludes the presentation. I'm open to any questions that anybody has going forward.
Hi, everyone. My name is Steve Dennell. I'm with the American Heart Association. I am the national lead for our post-acute certification program, and I just wanted to thank everybody for joining this lecture. Thank you so much, Dr. Telechia. Before we get started into answering questions, and you can type on the page, it's in the live chat, your questions, so please continue to type questions in, and Dr. Telechia will be able to answer any questions that you might have. Before we get to the questions, just to share a little bit about the certification program. Our post-acute heart failure center certification for skilled nursing facilities was officially launched in July of 2019. We have had an exciting year, despite the challenges with the pandemic. As Dr. Telechia shared, we currently have 11 facilities that are certified, and we have approximately another 20 that are working through the process right now and hope to be certified soon. There's as he shared, a lot of opportunity to improve care through the certification, and our intent as an organization is that, we walk alongside you during this process and really aid in, trying to, meet the standards, and we'll work with you to overcome, any gaps that you might have at this point. So I am gonna, if we could pull Dr. Telechia up on the video, and hey, Dr. Telechia, how are you?
Good afternoon. Great. Thanks for having me.
Thank you. So some of the questions that we have had come in, and one of the ones that I just wanted to kind of jump to is, how does a skilled nursing facility such as yourselves create an order set that is evidence-based, and what challenges did you overcome to make sure that patients with heart failure are actually being assigned to that order set and following it?
Yeah, so that I was trying to allude a little bit of that in the presentation, and that's a big fallback, and that's what we actually were encountering earlier on, is that we'd get patients who were admitted from the hospital with heart failure, and even though I knew that they were coming for heart failure, or administration knew, when they reached the floor, it wasn't disseminated onto the admissions team. What you don't want to do, you don't want to create a system where every time somebody has heart failure, I have to personally get involved to make sure that these order sets were done. So you want to make sure that that passes through from the hospital to the PRI to the admissions set. So we actually have admissions nurses and the nursing managers on the floor who are in charge of the actual electronic PRI, while the nurse practitioner is taking the paperwork from the patient. So that's where the fall off happens. So we put it on the nurse managers who get the PRI, who see that the primary diagnosis code, I-50.9 or heart failure, whether it be with reduced ejection fraction or not. When they see that, that then tells them, oh, this is a heart failure patient. They automatically know, because they've been trained and in service, that this is now a telemetry patient. So when we created on Sigma, we use Sigma Care. Most post-acute care facilities will either use Sigma or point-click care. But with ours, with Sigma, you can create an order set, and once the telemetry order set, then there's a lot of drop downs that will tell you, do you want echocardiogram, EKG, put them on telemetry, chest X-ray, all the labs that'll go in, the heart healthy diet. So it's already built in once we know on the PRI, when the patient's coming in, they're coming in with a primary code of heart failure. Once that order set's taken in, the nurse practitioner is there to sign off on the orders. At that point, she will then review the record and the discharge summary to see what was done in the hospital, what medications were done, was there an echo like I was talking to on the presentation, was it done in the hospital? If not, do we need to get one here? And then move forward and screen them accordingly.
So you talk about, and again, about especially with the patients, coming from the referring hospitals, what challenges have you had to overcome in terms of working with your hospitals? Because again, as you kind of alluded to, that's kind of really the glue that's going to make this work for you all.
Yeah, absolutely. So the biggest challenge, I would say, was the cardiology itself. So I think a lot of people out there listening or trying to get the certification process, even though it's not required they have a cardiologist on staff or in-house at all times, you want to make sure that there's sufficient cardiac follow-up. And since we were creating a telemetry unit, we want to take the extra step where we're well covered with a cardiologist looking at the strips regularly. So the biggest pitfall or challenge for us was make connection with the cardiologist in the acute care setting to get them interested into organizing and collaborating with us in this program. But once they sort of understood what we were trying to do, it was just really about getting in the door. Once we're in the door, it became somewhat seamless because they understood the importance of what we're doing and what we were trying to do to help the patients.
And how do you work with them through the patient's stay and post-discharge from your facilities?
So 95% of our patients come from one hospital system, which is the Montefiore Hospital System. So I've actually become credentialed at Montefiore. And so part of it's on me to become known to them as well. So being that now I'm affiliated with the hospital, I go to their grand rounds, I meet everybody. So there's now a close communication with the physicians themselves. So that helps garner a relationship as well, where I could then call them directly to find out any information or follow-ups or insight on what's going on with the patient.
So how with your skilled facility, how are you working with your patients at discharge and post-discharge?
So that was also something that we spent a lot of time, because you don't want to bog down the social workers. Once the patient is discharged, they're going to be spending all their time on the phones with these 48, 72-hour, 1 week, 2 week, 3 week, 4 week phone call follow-ups, which can accumulate over time. So we've created actually an algorithmic system where we have a call center that the patient calls into, and from there, do they need a physician or do they need a social worker? For the most part, it's going to be those two entities, because whether they need transportation or their medications, or they have a red flag sign and they need help because they don't know if they need to see a physician right away, and they were just discharged, they haven't had their follow-up with their PCP or cardiologist. So having that call center rather than just social work is key, because again, the social workers already have enough on their plate, the social workers, where you don't want to tie them into it, because I think that can lead to things getting missed.
So from an education standpoint, who has who's principally done the education with your staff around heart failure? Has it been pretty much learn on their own, or have you brought third party in? Even the hospital you say you work with a majority of the time, or is there certain educational modules that you're having them learn through for your staff?
So it's a little bit at a time, but yeah, we have a nurse educator here that's in charge of educating the nurses, and the education that our cardiac unit is getting is different than the rest of our post-acute care unit or long-term care units. So the specific team members that are going to be a part of the cardiac unit are all in service and trained with different modules. So we actually trained all of our nurses and nursing managers, because IV diuretics are not routinely given in a subacute rehab. But as a subacute rehab, I think everybody would agree that acuity is rising slowly. We have to become a little bit more aggressive. So we have in service all of our cardiac unit nurses and LPNs on IV diuretics, so the LPNs don't really give it. So it's a slow process, and we're still evolving, as I alluded to. We're going to bring in more staff. We're going to have 24-hour RN coverage with two. For the ratio is going to be different. So as we bring them in, they'll be educated as well. We haven't partnered with the hospital at this point for education purposes. We're doing it all in-house.
Okay. You had a slide, which I thought was really good, that showed about the quality improvement. I know it's a standard as part of the certification, but can you just shed some light on how you all are doing quality improvement within your facility, and where have you made some strides or impact?
So I first started with the quality improvement on the clinical side. I think it's not only clinical. You could make sure that the calls after discharge are coming in, or that the patient was educated properly on a heart healthy diet before discharge, or medication adherence by the nurses before discharge. But what I started with was, I think the easiest for me was the clinical side, where we had developed templates on what medications they came on. Was the echocardiogram done, or was left ventricular function assessed during their hospital stay? And at first, you joggle your mind, how are you going to address and collect this data, which is where the templates came from. And I have multiple people doing it. So my cardiologist, I've adjusted his template to make sure that these certain points are addressed, and he puts a value next to them. Same thing with our admission, our H&P, and same thing with that nurse practitioner intake note as well. So you do it from 3 different levels, just to make sure, even though it's redundant, that it's verified. Once you have that, I actually personally do the quality improvement data collection and analysis. So I actually dig out the diagnosis code addressed on each, or connected to each chart. And if I find that these patients' primary diagnosis code is heart failure, that's when I start sifting through. And I do that random. And I know for the most part who my heart failure patients are, so it becomes a little bit easier. But that's sort of how I do it. I compile it, I filter them out, and then I go through the notes. And I say, okay, and I make sure it matches the order. And were things done and changed accordingly? And that's sort of where you gather your data and see where you can improve. And we had done that actually with the beta blockers. We were actually tried to do the quality improvement with ACE inhibitors, but in my population, geriatrics, renal disease is prevalent. So a lot of patients aren't candidates for ACE inhibitors. So that's sort of like, I can't really assess this. I'm never going to get to my goal because many patients don't qualify. So now you have to sort of standardize your template saying this patient isn't a candidate because of. So it helps guide you in different ways. But we're still a little bit early on the quality improvement. I'm sure there's much more to be done outside of the medical aspect.
So going through the process, I'd be curious from your perspective, what were three things that I don't want to say surprised you, but that kind of that you would take a step back and say, hey, this was really important, as you went through the certification process?
So 3 things that I found really important. Number one is right in the beginning, we were trying to make this heart failure program and coming up with the idea. And I found, it's kind of hard to create a skeleton on your own. I think I alluded to this in the presentation as well, where the AHA helps with that, where you guys have provided us with everything that's required to become certified. But in those requirements, you sort of form this template of care that can be provided in our facility, because you know about the heart healthy diet, you know about the medications, you know about cardio, but how do you piece this all together succinctly where you're providing adequate care? So I think having that skeleton from the AHA was important. Another one, which is more clinical, is the cardiopulmonary rehab itself, because I think it's something that we always, in the medical profession or in our cardiac patients, we talk about all the time, but it's not readily available to us. And now that I'm seeing it, I realized how important it is to provide this to our patients with heart failure and the benefit that it can provide. The third one that's really important is diligence. This is a constant battle, not a battle, but you have to constantly be pushing forward with this. If you're not moving forward, you're moving backwards. So that's why we meet regularly to make sure that we're modifying all the little kinks in our program, because I think it still is in a fragile state. So if you don't stay on top of it, if it doesn't become second nature, it can fall apart. So you have to be diligent in this process, despite it taking over a year, because as it comes together, as it comes to fruition, you see what you can do with these patients.
So as and again, just knowing a little bit about your program and really congratulations on the phenomenal work that you all are doing. As you continue to improve on your outcomes and obvious other parameters such as readmission rates and so on, how are you going to use that information, maybe to leverage payers or to work with other hospitals, to be able to, showcase, how well that you're doing and the outcomes that you're having?
Yeah, I think it's about data. I could put in, forgive me, I don't mean to speak about the AHA, but I could say, I have the credential from the AHA and I'm the only one in the Bronx that has it, come to me. But the data is going to speak louder than that, right? So my patient outcomes, my readmission rates, which is what we're tracking as well, that's going to speak louder than anything. I think that's what the physicians in the acute care setting want to see as well. Sure, you say you have this, but are you doing something? So I think most programs out there, most facilities out there are going to say, yeah, we have a heart failure program, but does it work? Are you putting in the work in to improve the outcomes for your patients? So I think data showing that we have better outcomes is what's going to be most important moving forward, because we already have the program in place.
What would you recommend to facilities or to other skilled nursing facilities throughout the country? I think I think we have approximately about 1,500 clinicians, attending, the expo today. And, a lot of them, are going to be like, how do I get started with this? Or, what things, and they may be just starting from scratch, whereas, your system, your skilled nursing facility was pretty advanced. What would be some things that you would recommend that they do to just get the ball rolling, to working towards developing a heart failure program in their SNF?
I think if you have somebody that's motivated enough to want to carry this out, I think that's all it really takes is one person to spark it, to be the team leader, to say, okay, because I think it's easy to conceptualize some of the things that you'll need. It's just going to be about putting it all together, which is like I said, what the AHA provides us with. So it was really a two-headed monster here between me and our administrator, Moshe Blackstein. Bruce sat down, all right, well, we need a dietitian. Okay, well, we need the director of physical therapy, and we need to develop a cardiopulmonary program. How far are we going to take this? So you need to have people who are going to be the driving force and start piecing it together. Because as you do pieces together, clinically, administratively, operationally, those questions will come up. Natural questions of how do I put this together? How do I make this admission seamless? How do I put this order set in? But as you create your team, as you get your specialist on board, you'll knock out these things one at a time. And it's going to take a long time. It's not going to be from today till tomorrow. When I first started this, I thought it was going to be 1, 2, 3 in 1 month. We'll get this rolling, but it's not that easy. Even when you put a patient, your first cardiac patient, into the room, things fall out and they start complaining. Oh, okay, we need to adjust this and go in a different direction. I think once you have your team together, then reaching out to the AHA and saying, "Hey, I want to be certified." I think it'll be as simple as that. The AHA will help you with the requirements that are needed in order to get certified, it's not very difficult to sift through and organize, as well as the different players in AHA who we're in contact with were extremely helpful, and available to us when we needed it.
You brought up at the beginning, that it's important to have a champion. Can you expound upon that? I know your passion towards this is obviously evident. But how important, and does that person need to be a cardiologist, or can you have somebody, a general practitioner, or even an administrator who really wants to move this forward, to take this to the next level?
Yeah, I don't think you need a specific person. I think you're going to need at some point somebody with some knowledge about heart failure. That's going to make the process easier. Me being a physician, I think helped Moshe out in getting those clinical aspects organized, and then vice versa, where I had questions operationally, he was able to help me. So having somebody clinical and non-clinical, I think, is important, but it's not necessary. I just think it'll make the process easier for you. And then as far as the importance, like I said, you need a driving force. You need somebody who's going to take responsibility, somebody who's going to be in charge of making sure that the team members get together and have discussions on what needs to be improved, and writing these things down, documenting it, leading the conversation, and guiding the conversation.
So to kind of go back, you've been certified, and you were talking about quality improvement. Where do you envision your program? You're certified now. Where do you envision your program kind of continuing those next steps to, even expound upon, the great work that you're doing now?
For me, it's growth. I want to grow the subacute rehab. I want to take on as many patients as we can. Right now we have the 3rd floor, which is being built out to be a cardiac rehab. It's going to hold about 40 patients, and I want to use that to its maximum capacity, with the ultimate goal of having good outcomes. I'm competitive by nature, so I want to be better than everybody else. But that takes a lot of work.
Yeah. Our time is coming to a close soon. Any last comments that you want to make?
No, I would just say this process takes a little bit of patience, and like I said, diligence, which is an important quality you're going to have because it's not a fast process and there's a lot that's required. Even when you submit your application for certification with the AHA, they're going to want to wait at least 6 months to review what you've done in the previous 6 months clinically, operationally to improve the cardiac program. And then it'll probably take another 6 months to organize that. So the process really takes about a year, I think. As this goes on, it may become easier. I hope it does. But you got to stay on top of it.
Well, thank you. And I wanted to thank all the participants on the call. This has been, a vast amount of information about our certification program, and really one of the facilities that have gone through this earlier on. As you said, Dr. Tellechea, it's like the first in New York. So this really is, an opportunity to take his knowledge. And I guess one of the questions that I got from the last lecture I moderated on post-acute certification was, would you be willing to, share your contact information so if anybody has any additional questions that they can reach out to you?
I have no problem.
Okay, great. Again, thank you so much for this presentation and your time to answer these questions today. And thank you for the participants. And we will close this session now.
All right. Good luck, everybody.